Welcome, Joanna Moncrieff. I'm very happy to have you today on my videocast. You are a professor of critical psychiatry, critical and social psychiatry at the University College in London. So I would like to start there. I once studied insects, and if I had become a professor of entomology, I would not have become a professor of critical entomology, because all scientists are supposed to be critical. So please explain a little about yourself and how you got that title.
Well, that goes back to when I started the Critical Psychiatry Network up in the 1990s. So right from the start, I wasn't really aligned with the mainstream view that mental health problems are just the same as physical health problems. I felt that there was something different, something importantly different about them, and that we couldn't just treat them in the same way that you treat lung cancer or liver disease or whatever it is. And so I started reading people who had been critical of the underpinnings of psychiatric thought, people who were referred to sometimes as antipsychiatrists, but also just regular sociologists who talked about labeling theory and various other relevant theories. And that convinced me further that psychiatry was quite different from the rest of medicine, and that some of the fundamental underlying premises of psychiatry were incorrect. And I started up the Critical Psychiatry Network to try and basically identify and collect together people who shared my doubts about the mainstream view. So so I've had that interest all along in trying to develop an alternative understanding of mental health problems, and to understand more what's wrong with a mainstream view and what the consequences of it are. And so when I came to be a professor, I wanted that to be part of my title, because it's been my long-standing interest and area of work.
But even so, it's I have never heard about this before, that university agreed to put critical into a professor title. That's really something, I must say.
I expect they didn't scrutinize it too much. They might have done today.
Okay. Oh yeah, maybe they didn't know what they would get when they got you, because you are terrific in many ways. I have learned a lot from you, and I'm very honored to be a member of the Critical Psychiatry Network that you started 24 years ago. And there is a lot of good communication there, where we try to educate each other and help each other, and it's very fruitful. Now, one of the things that I stumbled across quite early was your books. Particularly this one. I'll try to show it here. A lot of pills on the front page, and then it says the bitterest pills. And there is a subtitle, The Troubling Story of Antipsychotic Drugs. So what you did with that book was not precisely making an advertisement for these drugs. So perhaps many people see these drugs as quite controversial. So should we start there?
Yeah. I mean, antipsychotics are the sort of emblematic treatment of psychiatry, really, in the modern era, aren't they? Since they were introduced in the 1950s and 60s, they are the treatment that is presented as targeting schizophrenia or psychosis, the most serious condition, the most serious mental health condition that there is. And when they were introduced, they were hailed as these miracle treatments that were the first treatment that actually properly medically targeted the underlying disease and made a real difference to the patient's actual condition. And I suppose, I've always been interested in them because from the first days when I was working as a junior in the old mental asylums before they were closed down, it was clear to me that there was a big disjunction between what it said in the textbooks about these miracle drugs targeting dopamine imbalances and the reality of people who were clearly tranquilized, shuffling around, zombified, as it's often called, and that didn't seem to me to equate to what was being proposed that they were doing in the textbooks. So that's one of the things that set me off thinking about my idea about models of drug action and thinking about other ways to explain what antipsychotics were actually doing to people.
Oh yeah, we will come into that quite soon. Now that you mention it, that they zombified people, and the original designation of these drugs was actually more honest, because they were called major tranquilizers, and this is really what they do. So to call them antipsychotics, like antibiotics that can kill bacteria and cure you, that's something of an exaggeration. So maybe you will come into this area.
Yes. So what's interesting when you look at the history of these drugs is that the people who first used them and discovered them really were much more honest about the effects that they had. And they called them major tranquilizers or neuroleptics, which has a similar sort of meaning, to sort of seize or restrict the nervous system. They were even referred to as neurological inhibitors by some people. And they recognized and they wrote about the alterations, the profound alterations that these drugs produce to normal consciousness, how they slowed down thinking and numbed emotions. Now, they were enthusiastic about the drugs. They thought they were better than what they had at the time. They were better than the barbiturates that just zonked people out. But nevertheless, they recognized that these drugs were not normalizing anything. They were inducing an abnormal state, a drug-induced state that was superimposed onto the psychosis or whatever it was that someone was undergoing.
Oh, could I stop?
Yeah.
Could I stop there, Joanna? Because I feel this is incredibly important. So let's repeat it. So in modern times, people have tried to market these drugs as if they could somehow almost cure schizophrenia, or at least make people much, much better. And then you say that's not what they do. They create another psychological state. So now the patient has both the schizophrenic symptoms and then some quite new state.
So we might slightly disagree on this, Peter, because I think that sometimes this new drug-induced state does help to dampen down the underlying psychotic symptoms, and is for some people preferable. So there are some people who sadly seem to sink into a psychotic state that they just don't come out of. And I think sometimes the drugs can just suppress all the psychotic thinking that's going on enough to enable them to re-engage with a bit of normality. So I think sometimes that altered state can be helpful, but it's really important, I think, to acknowledge, as you say, that the drugs don't normalize anything. They are creating their own state, abnormal mental and physical state. They're creating an abnormal brain state that has the consequence of slowing up people's thinking and blunting emotions. And it just so happens that sometimes for some people who are trapped in an intractable psychotic episode or psychotic state, that sometimes that can be better than living with the psychosis, or can give them can help them come back to reality to enough to engage with people a bit.
Yeah, I realize that. But then there are also the benzodiazepines that if people come in an acutely psychotic state, trials have been made comparing benzodiazepines with neuroleptics. And benzodiazepines so far seem to be a little better than neuroleptics in calming people down. So there is an interesting question, namely benzodiazepines versus neuroleptics. trials have been made that compared the two kinds of drugs in acute psychosis. And it seems that benzodiazepines are slightly better at calming people down. And when I have lectured for patients and asked them, what would you prefer for your next psychosis? Everyone has said a benzodiazepine.
Yeah.
So I think it's reasonable to question, maybe it would be better to use benzodiazepines because they are not so dangerous if you have an acute episode. What do you think about that?
So I agree with you to some extent. I think they could be the first line treatment. However, and not only do they calm people down, there is some evidence that they actually reduce psychotic symptoms as well.
Yeah.
And that may again be by reducing arousal. Um, and they are less unpleasant for people to take and probably less dangerous. Obviously, they have dangers and harms as well, but probably overall less harmful than taking antipsychotics. I think the problem with them is that people build up tolerance to their effects so quickly. So the effects may not last. And I just don't have enough experience of using them in that acute situation to know how much of a problem that is. But I agree with you in principle. I think we ought to be, trying them out more, particularly as you say, because they are just much more preferable from the patient's point of view. And the other situation where they make sense to use is acute mania. I mean, acute mania is a disorder of over-arousal, and the main symptoms are not being able to sleep and having boundless energy, not being able to shut down. So obviously something like benzodiazepines might be helpful in that situation. And again, the limiting factor would be, I should think, the extent and the rapidity of tolerance.
Yeah. One of the things you have done in your research career is that you have written several articles about what you call the disease-based model of drug action, and the other one is the drug-based model of drug action. I think this is very important, and you should tell the viewers about this.
Yes, thank you. So I alluded to it already when we were talking about antipsychotics. So the disease-centered theory of drug action is the mainstream view that is either presented or assumed in most psychiatric and psychopharmacology teaching and textbooks at the moment. And that is the idea that drugs like antipsychotics, antidepressants, mood stabilizers, etc., work by targeting the mechanisms, the underlying biological mechanisms that produce the symptoms of the condition. So thinking about antidepressants, the idea is that the antidepressants target the underlying pathology that produces the symptom of depression. It used to be thought that underlying abnormality might be an imbalance in serotonin or noradrenaline or one of the neurotransmitters. I've hopefully, and other people have shown that there's really not evidence to support that point of view. Nevertheless, there are many people who cling on to the idea that antidepressants are doing something that is directly affecting the underlying biological mechanisms of depression that produce feelings of depression. And really, it's so important for people to realize that we have no evidence to support that theory. We have no evidence that there is a biological underpinning of depression or psychosis or anxiety or bipolar disorder that might explain the action of the drugs that are given for those conditions. So no evidence of a serotonin imbalance that SSRIs could be correcting. No evidence of a dopamine abnormality that antipsychotics could be correcting. And so the alternative way of thinking about what these drugs are doing is what I've called the drug-centered model. And I called it that to emphasize that these substances are drugs. That is, they are chemicals that interact with the body and by definition change its normal state. And the drugs that we give for mental health problems are drugs that cross the blood-brain barrier. So they change the normal state of the brain. They change our normal brain chemistry and functioning. And the changes they produce to the brain produce changes in consciousness, changes in thinking, changes in emotions, and changes in behavior. And it's those changes, those drug-induced changes, which when they're superimposed onto underlying mental health symptoms, may be perceived as improvements. So we talked about how antipsychotics typically induce mental slowness and emotional numbness, loss of spontaneity, loss of initiative. And these have been well demonstrated with antipsychotics in volunteer studies and animal studies. You can show that these drugs dampen down almost all aspects of cognitive functioning and create this sort of emotional indifference. And if you induce that sort of state in someone who is highly aroused and highly invested in paranoid or psychotic delusions or phenomena like hallucinations, if you damp those down by the effects of this drug, then obviously that person will appear to be improved.
And yet, when you do placebo-controlled randomized trials of these antipsychotics, the measured effect is so small that it is actually way smaller than what psychiatrists consider the least clinically relevant difference. So on average, they don't do much, but I agree with you that sometimes some patients can see them as being helpful, but they are not very helpful on average.
So the trials show that, and I think there are many patients for whom they are not very helpful.
Yeah.
I think there are probably some for whom they are a bit helpful.
Yeah.
And they do damp those symptoms down enough, as I said, to just enable them to have a bit of a life and join in with reality again. One of the reasons that the trials don't show big differences is there are very few trials that have been conducted well with people who have acute psychotic symptoms. And the ones that have generally not managed to maintain the people who are really psychotic in the study. That those people drop out. So I think that's, I just don't think we have terribly good evidence on the effects of drug treatment of people who are acutely psychotic. And then the other problem that I know you know well is that once you've started people on these drugs, and then if you take them off them, you get into all sorts of problems. And a lot of the studies we've got have been studies that actually have started with people who are already on the drugs to begin with, and are therefore not really giving you an accurate picture of how good the drugs are in the first place.
But allow me to be a bit cynical here. Virtually all randomized placebo-controlled trials have been done in people who are already on the drugs, as you say. And then those who are randomized to placebo, some of these people get withdrawal symptoms. And then you conclude that the drug is better than when we harm those who are randomized to placebo. That's not very, very good studies, I must say. And this is virtually every one of them.
Yes, no, absolutely. And for example, I mean, I learned this from reading Bob Whitaker's book, Mad in America. All the trials of the atypical antipsychotics that came in the 1990s were like that. They just went into a ward or a nursing home that was full of people with chronic psychosis or schizophrenia. They took half of them off their medication and put them on a placebo, and half of them they transferred to olanzapine or whatever it was. And lo and behold, there was a difference.
Yes.
I mean, how those studies ever, and I remember in the 90s thinking it's really odd that they can do all these prospective trials so quickly, that all these studies about these new antipsychotics are coming out so quickly. Never once, it didn't occur to me till I read Bob Whitaker's book that this is what they were doing. They weren't starting people newly on their new drugs as you really need to show whether they really have some benefit. They were just going and finding people who were already on them.
It's very strange that there weren't very strong protests against this unethical research design. But Whitaker has also written that the rate of suicide was 2 to 5 times bigger in these withdrawal trials than otherwise in patients with schizophrenia. So people were really harmed in many of these studies, at least some of them.
Yes.
But there, I would like to come back to one thing you said, that I suppose you agree with me that it's pretty strange that people have looked so hard for biological explanations for depression when, for example, one psychiatrist told me, by far most people who are depressed, they're depressed because they are living depressing lives. I mean, it is life circumstances that make people depressed. And why should you look for some biological cause in the brain for that when it's outside the brain?
Yeah. Yeah. I mean, the story of how psychiatry has regarded depression is very interesting. And I don't quite understand why depression is so important to the profession, but it seems to be. It seems to be more important to the profession of psychiatry to show that depression is a biological condition than to demonstrate that anxiety is a biological condition for some reason. And maybe that's because it's the most common sort of non-serious, non-hospital-based condition. And so therefore to justify the existence of psychiatry outside the asylum, depression was seen as identifying depression as a biological condition was seen as a key argument to justify the existence of psychiatry outside of treating people with really severe mental health problems like schizophrenia. Because I mean, again, what's interesting about reading the history is that there were people there were psychopharmacologists and psychiatrists in the 1950s and 60s who were aware of these problems with trials, who were aware of withdrawal effects, who were aware of placebo and amplified placebo effects, who were interested in the sort of alterations the drugs produced and concerned about them. There was George Crane, who highlighted tardive dyskinesia. And it seems like that sort of more critical attitude got swept away over the 70s and 80s and then completely annihilated in the 1990s when all the publicity around the SSRIs came along. And I can only think that it was really psychiatry gets swept up in this idea that it's, a proper modern medical specialty, that it's got specific drug treatments, that it's the same, that it's the same as the rest of medicine, that it's sexy and glamorous and, macho, and people stop asking those difficult questions.
There is another of your contributions to science that I really treasure, and that is many, many years ago, mostly in the 60s, some trials in depression were made where people had put atropine in the placebo in order to blind the trials better. So the psychiatrists couldn't guess based on side effects whether patients received active drug or placebo. And since deciding whether a patient is improved is highly subjective, it's important to blind the studies. And when you did a review of these atropine placebo trials, you found, as expected, that, now that we cannot guess who get what, the effect was smaller than in the other trials.
Yes. And again, those trials were done when there was still a climate of asking those sorts of questions, of thinking, well, what are antidepressants really doing? Are they? Because as well as the active placebo studies, people were comparing antidepressants against antipsychotics, against barbiturates. One of those active placebo trials, they had the placebo contained atropine and a small dose of a barbiturate, for example, because they were. The antidepressant in those trials was a tricyclic antidepressant. They all tested a tricyclic, and tricyclics are very sedative. Now, atropine can mimic the dry mouth you get with tricyclics, but it's not sedative, quite the opposite. So actually, although it's better than nothing, taking atropine isn't really the same sort of experience as taking amitriptyline at all. But taking atropine and a bit of a barbiturate is probably getting a bit closer to the experience of taking amitriptyline. And that was the best of those active placebo-controlled trials done by two very well-known psychopharmacologists, John Hollister and Leo Hollister and John Overall, and that found no effect, no difference between the active placebo and the antidepressant.
Yes. Now, I think a couple of years ago, you published an article that received a lot of attention, and much of it was not very unpleasant for you, I guess. And that was when you did a systematic review of this chemical imbalance myth and demonstrated that the emperor has absolutely no clothes on. You did not become very popular based on that one.
So the reaction to that paper was extraordinary, really extraordinary, I would say. So the first reaction was, oh, it's not news, that's just boring. We all knew that. We all knew there was no serotonin imbalance in depression. But of course, the next question is, well, why have you let the public continue to believe this for such a long time? If you knew, why haven't we been broadcasting this and informing people? There were examples just weeks before we published that paper of doctors going on BBC national television and radio telling people that depression was a chemical imbalance. So that was the first reaction. And then sort of alongside that and then building up afterwards was, oh, no, OK, but it's, well, it might not be serotonin or a straightforward serotonin imbalance, but it's more complicated. Serotonin is involved in some way, or it might be neurogenesis, or it might be electrical circuits, or it might be this, or it might be that, or it might be glutamate, just throwing hundreds of other ideas out there. And my conclusion is that some members of the profession are absolutely desperate for people to believe that depression has a proven biological basis. And they really, really don't want people to question that. And they don't want people to be told that that hasn't been proved. They want people to go on under the illusion that it has been proved. Because of course there are studies going on, of course there are theories, that was always the case. But what has changed over the last 30 years, and it changed when the pharmaceutical industry started campaigning on it, is this, people have been given the idea that it's proven, that we know that depression is related to a serotonin imbalance.
But it has been a means of persuading patients who might not like the drugs. For example, they give them sexual harms and so on. They can't have a normal sex life and all the other harms. So to tell them that you have an imbalance, so we need to fix this imbalance. And one psychiatrist professor in Denmark wrote in a Danish newspaper that, oh, we abandoned that theory 20 years ago. And then when I debated with him at a university in Denmark, I recommended not to use so many depression drugs. Then he said to the audience, would you also take insulin from a diabetic? And this is exactly the chemical imbalance. So he did not abandon that idea. And when we did a review of popular websites that ordinary people would easily find, 39 popular websites in 10 countries, my Australian colleague, Marianne Dimasi, and I found that 3/4 of the websites, and we did this study just a couple of years ago, actually talked about a chemical imbalance or that a drug could fix an imbalance. So
that was a great study, Peter, that I've cited many times. And since our paper was published, I do sort of Google searches now and again, and it's still all over the place. This idea that depression is caused by a chemical imbalance is on loads of websites everywhere, easy to find. And I mean, I think sort of drilling down into why it was so threatening to expose that idea as being untrue or unproven. I think the problem is that it throws into question, it disproves the disease-centered theory of drug action. So it says, okay, we've got no grounds for claiming that antidepressants work by addressing an underlying biological abnormality. Then you have to go to the drug-centered model of drug action. The first thing that should make you ask is, well, how are the drugs changing the brain? What are they, how are they modifying it, and what might be the harmful consequences of doing that? Because normally it's not a good idea to, take drugs that change your brain chemistry year in, year out. So first of all, that will rightly make people more concerned about taking antidepressants. And secondly, it suggests that if there is a benefit of taking antidepressants, and I'm not sure that's certain at all from the evidence from the trials, but if there is, the drug-centered model would suggest that may be due to the emotional numbing effect that you get from antidepressants. And some people might decide they want a bit of emotional numbing, but that's not what people who have been told that they have a chemical imbalance have generally signed up for. They have not signed up for something that numbs them like Valium.
No.
And that was, the marketing of SSRIs in the 1990s, the marketing of this idea that there was a chemical imbalance and the SSRIs were, the drugs that could correct that, was deliberately intended to overcome people's reluctance to take a drug for emotional problems.
Yes.
Because people generally perceive taking drugs for emotional problems as simply numbing or, plastering over the problem and not really doing any good.
It's a bit like taking aspirin if you have a broken leg. I mean, it might lessen the pain, but you still have a broken leg. I try to tell people that you did not have a chemical imbalance to begin with, but since you took a psychiatric drug, it has created one in your brains.
Yeah, absolutely. That's really important for people to know. But I think it's even worse than taking aspirin for a broken leg. I think the analogy is taking alcohol for the pain of a broken leg. Yeah. So alcohol might have aspirin does target pain. It doesn't help with the leg, but it does target the pain. Alcohol maybe has a bit of a targeted action on pain, but alcohol also just makes you intoxicated. So you forget your pain. You're distracted from your pain. I think what antidepressants and antipsychotics and everything are doing is a little bit more like that. They're creating this different state that is superimposed, that doesn't directly target the underlying emotional problems, but may temporarily distract you.
There is one thing I came across just recently. A Norwegian colleague, he informed me that in a major Norwegian newspaper, the Norwegian Psychiatric Association had come up with some statements, several of which were clearly untrue. And this debate has then continued, and some psychiatrists in Norway, they say that, we must use these psychiatric drugs because they can be life-saving. I have never seen it documented that psychiatric drugs can be life-saving, but I have seen it documented that actually quite many people are killed by them. This has been documented. And then they say also that antipsychotics help people get back to a normal life. And I have not seen any documentation, quite the opposite, that it's more difficult for people to come back to a normal life. So I feel this level of dishonesty is really concerning.
Yeah, no, absolutely. I mean, on the Panorama program that was screened in the UK recently about antidepressants, one of our leading psychiatrists was on there saying antidepressants save lives. Just as a blanket statement, as if that's been well established. Of course, it's never been established that antidepressants save lives. What has been established is that antidepressants actually increase the risk of suicide a little bit in younger people, possibly in older people too, but certainly in younger people. I mean, it's just...
And not only that, one of your British colleagues, Copeland, she published in BMJ what happens when you give elderly people depression drugs. And this was not a randomized trial. It was a big sample of patients. And they documented that, oh yes, these drugs increase mortality.
Yeah.
And one of the reasons was via falls.
Yeah, yeah.
Like
Yeah.
with benzo sleeping pills, that you walk more unsafely. And if you fall and break your hip, then 1/5 will be dead within the next year.
Yeah. I mean, those studies, those longitudinal studies of mortality are difficult because there's lots of uncontrolled factors, and so people will always argue about their findings.
Yeah.
But we know that antidepressants increase the risk of osteoporosis, that they increase the risk of bleeding, and that they cause dizziness, and all those things are obviously and that they have cardiac effects, and all those things may logically contribute to increased mortality in older people in particular.
Now, I wonder, have you ever thought about the drug industry is very powerful in dictating how many psychiatric drugs a population takes. And as Bob Whittaker has shown, in all countries he has studied, the more psychiatric drugs people take, the more people come on disability pension because of mental health disorders problems. So it's the opposite of helping people getting back to a normal life. Have you ever thought about how little should we use psychiatric drugs compared to the usage we have today? Do we have any idea about that?
Yeah. Well, my view is that we should massively scale it back, and that really drugs are useful for a proportion of people who have psychosis. Some of them probably long term as well as short term, but not. We know that there are some people with psychosis who probably don't need the drugs, and definitely will get better in if you give them time anyway. And that the vast majority of people with anxiety, depression, PTSD, OCD, etc., would be probably better off not taking psychiatric drugs. Possibly there's a role for occasional benzodiazepines for some people who are very anxious, but it's it's really important that people avoid getting dependent on them, because that can lead to lots of problems.
Yes.
But my view is that we need to fundamentally demedicalize mental health and really take it out of the medical system and put it into the social work system, so that instead of treating people's brains, we're treating people's problems, people's life problems that are causing them to feel anxious or depressed. And of course, people, some people are more vulnerable than others, again, largely because of what's happened to them in the past. But there is there's a certain amount of unexplained difference. We're all biologically different, so some people are going to be more susceptible to anxiety and depression and things than others. But even if there is some sort of biological predisposition, that doesn't mean that we have a biological fix for it.
No.
We don't have this. There's some biological basis to temperament. We don't have a biological fix for having a difficult temperament. So the answers to helping people who are maybe more vulnerable than others are still the same things that you would do with everyone else, trying to sort out people's problems, encouraging people to live healthy lifestyles, get exercise, eat well, structure their time, have meaningful activities, have social contact, and then possibly occasionally for some people, some very occasional use of something like a benzodiazepine. But that's as much as I think drug treatment has to offer the majority of people.
Yes, so I would like to say that there is a huge job in front of us, because official guidelines for withdrawing psychiatric drugs, they have all over the world been very misleading. They have recommended a far too quick tapering, and then going from some dose to nothing far too quickly, when the low dose should have been divided by buying a guillotine at the pharmacy or a nail file and filing on the tablets or something. Because when you come down in very low doses, doctors don't realize that you are still high up on the receptor binding curve in the brain. So some people in your critical psychiatry network have been very important in this respect by writing articles and book chapters and helping people come off psychiatric drugs. So we are improving, but the official advice has been actually dangerous many times.
Yes. I mean, Dr. Horowitz, who I'm sure you'll probably interview at some time, has done some really good work on this.
Yes.
Spurred by his personal experience of, of the difficulty of getting off antidepressants. And what I would say is it's still really important, because I think that so many doctors don't recognize that the problems that people experience when they try and get off antidepressants may well be related to withdrawal. And many doctors just assume that if people start, getting a bit moody or anxious or tearful, that's a sign of relapse, and that they just restart the tablets. And I suppose in some ways that's the easiest thing for the doctor to do, isn't it?
Oh, yes. Could I just mention that you and I met for the first, and so far, unfortunately, only time in 2014, when there was a meeting in the House of Lords in Westminster, where we founded Council for Evidence-Based Psychiatry in the UK. And one of the founders had been terribly harmed by antidepressants and benzodiazepines. And when he told me about his withdrawal symptoms that persisted after several years, I had difficulty believing him, because I'm a doctor. I have learned a lot about clinical pharmacology. I had never heard about these symptoms. And it's the same with Mark Horowitz. If he had not had these symptoms himself, he would not have believed them. He has written about that.
Yes.
So there is a lot to be learned, and a lot to teach our colleagues about, so that we can do better.
So when I started to meet people like Luke and Mark, I went back to Heather Ashton's early papers on benzodiazepine withdrawal from the late 1980s and early 90s. And she was describing these persistent withdrawal states back then. She was aware that people who were coming off benzodiazepines, some of them had very protracted symptoms that lasted for months and sometimes longer. So there is a precedent. We did know about it. We didn't take much notice, and and I'm also guilty myself of not really having taken enough notice of it, not having struggled to believe it for a bit at first. But then, as I say, I went back to this literature and I thought, actually, this is not just antidepressants. This is, an effect of some drugs that affect the brain, clearly have cause ongoing symptoms. And it shouldn't really surprise us, should it? The brain is such a delicate organ. We don't know what these drugs are doing exactly. They are messing about with normal brain chemistry. They're not correcting anything. They are disrupting normal brain chemistry. So it shouldn't necessarily surprise us that actually there are long-lasting harmful effects, that there does seem to be some damage caused by them. I think you have to use that word, really. It's a very emotive word to talk about brain damage, but if you take a drug for a few years and then you have really severe symptoms for years afterwards that are caused by that drug, then what else is it, really?
Well, I actually had a look in your book, The Bitterest Pills, before this interview, and I found a page where you write that antipsychotics can cause neural damage, really. This has been shown. So it's good that you mentioned this. Now, I would like to ask you, I think this has been very interesting to talk about this with you. Is there something you would like to say before we finish?
Well, I think I'd like to say that I've come under a lot of criticism over the last year for expressing these views. I've been told numerous times that, my colleagues don't like it. I've had people refusing to work with me. And I am really concerned that there seems to be an atmosphere of a determination to stop debate about psychiatric drugs from reaching the public, and to try and, you know, shut people up and marginalize anyone who raises any concerns about them.
I agree, and I was also marginalized.
Yeah.
As you know, my criticism of psychiatric drugs was the reason the Cochrane collaboration kicked me out. I was not allowed to criticize these drugs. And to me, this is perhaps the worst part about psychiatry, that when you tell the truth and people tell you to shut up and freeze you out, it resembles a religious sect more than it resembles a science. This is really concerning for me. We must get away from this.
Yeah, yeah. Yes, absolutely. And of course, your experience is a very dramatic example. And the people who suffer are the general public,
yes,
who don't get proper information about
yes,
the tablets that they are being encouraged to take. And on that note, I'd like to say that what worries me a lot at the moment is the increasing use of antidepressants and other psychiatric drugs by young people who are being encouraged to take them by a sort of ideology that that mental health, that they're doing a good thing to come out as having a mental health problem, and that taking a drug for a mental health problem is somehow an act of solidarity with
yes,
you know, other people who have mental health problems. And I don't think that, well, I'm sure they're not all fully informed about all the adverse effects of the drugs that they are taking or thinking of taking. And that's really concerning. We haven't talked about this, and maybe this is a thing for another subject for another time. I know you've done some really useful work on this, but the sexual side effects of antidepressants that you mentioned, it's well recognized that SSRIs in particular, but all antidepressants, interfere with normal sexual functioning. But over the last few years, there's been increasing evidence that this sexual dysfunction can persist after people have stopped taking the antidepressants.
Yes. Yeah.
And particularly if we're thinking about a lot of young people starting these drugs, that's a very worrying scenario, even if it's quite a rare situation. So I just want everyone to be properly informed about all the risks that there are involved in starting these sorts of medications.
Oh yes, psychology professor John Reed, whom we both know very well, he said in a radio program, I think, in the UK not so long ago, that in surveys he had made, less than 2% of the patients had been told by their doctor that it could be difficult for them to stop an antidepressant when it was prescribed to them. And also very few people have been told about the sexual side effects, and particularly not that they can be more or less permanent in a few people. And it's a bit funny to call pills like that happy pills that ruin your sex life, isn't it? But that's a marketing term, of course.
Absolutely, absolutely. Yeah. And the absolute tragedy is that so many people are convinced that this is the right thing to do, that, you know, that they'll accept these side effects.
Yeah.
They'll just put up with them. And that's just terrible.
So shall we end on that?
Okay, Peter, it's been fun. It's been lovely to talk to you.
Thank you. Thank you so much.